Welcome to the Fat Emperor podcast. I'm your host, Ivor Cummins. We're going to be talking about coronavirus again today, and particularly the prevalence in the population of infection, which may be vastly higher than is being assumed, and also around the lockdown versus softer, smart measures which might be used, and what's giving a bang for the buck in this whole problem to flatten the curve. So I'm with Tucker Goodrich again. Great to see you, Tucker.
Great to see you, Ivor. As always, thank you for having me on.
Oh, not at all. I mean, you're a data guy, and actually, you might start by just a very brief overview of your past kind of professional experience, which pertains very strongly to this kind of issue, even though you don't have medical experience per se.
Yeah, so my experience, I was chief technology officer of a top 100 hedge fund on Wall Street for about 20 years. My expertise was building risk systems, which means, looking at models, evaluating new products to perform data analysis that are being brought to me all the time, and also analyzing claims and performance of traders, right? So key part of my expertise, to the point where salespeople were terrified to come in front of me, was listening to a case and that was being made to me and tearing it apart, figuring out where all the holes in the data were. The fellow I worked for 20 years was of a similar mindset, and one of our vendors said about him one day, "What is he, your assassin?" So yeah, so basically I look at this argument that's being presented to us about the coronavirus pandemic and how to handle it as if they're making an argument. If they're making an argument, they're saying, here's our intervention, here's the data that justifies the intervention. And my reaction is just very basic. Okay, let's check your assumptions and make sure if it's credible or not.
Very good. So let's do that. And very briefly, I mean, my background professionally in engineering, I was a problem solving team leader for most of it, or a manager, and not dissimilar. I mean, we ran massive issues that were highly complex with 9-month lag times between subtle material interactions that caused customer failure. And 9 months later, we began to get our returns. And then the data was insanely complex. And there were tens of millions and more of cash flow loss due to them. So there's a lot at stake. So I find this interesting, and I like to stay dispassionate, away from the personal side of it while you do the analysis. So obviously the personal tragedies are absolutely a big challenge, especially older and metabolically ill. And I know a lot of people like that personally who are at risk. But we got to put that aside and look at the numbers. Like you say, argue the case based on the data. So we might start with the prevalence. So many weeks ago, when this kind of started getting legs, I thought, okay, it's very highly infectious with an R value at 3 or 4, whatever. It became apparent the first cases were in the UK in January and spreading to kids and other people, and in the US in January, and then Italy maybe in November. And I thought, if we only start locking down in mid-March, a couple of months have passed with the doubling effect every few days. Have not absolute masses of people got this in the Western world before we locked down? So if the first cases were, say, January, then it's going to be February before you start really seeing a response in the system. But by March, mid-March, you're going to have a huge amount of transmission would already have occurred, whatever about what you're seeing in the hospitals, because that's going to have a big lag. So this point about prevalence in March before lockdown in Europe and America could be pretty huge. And there's recent Italian data, and I think you mentioned German data just coming out in the last few days, talking about very high percentage rates of infection, vastly beyond what's being assumed by a lot of the data that.
Yeah, and let's discuss briefly what they're doing with this testing. I was pretty upset early on when people were promoting testing as a response to this. for a couple of reasons. The first was the SARS epidemic of 2003 was contained without testing. They just did standard epidemiological practice. You know, you've got the symptoms, contact tracing, and cut down, you know, and then quarantine people who are likely infected. That was effective in containing that SARS epidemic, which, to be fair, was much less contagious than this appears to be. The MERS epidemic was completely different. Apparently, you mainly get that from camels, so it's not a threat to the general population. But so the notion that we were going to be able to stop this with testing was pretty unlikely, just because it was pretty obvious early on that this was way more infectious than SARS-1. And then you get into the next issue, right? And you and I know this from our professional experience. You never buy something to solve a problem if the product doesn't exist. I mean, that should be pretty obvious, but they didn't have testing available to do what they were saying they were going to do, which was what, you know, South Korea seems to have done pretty effectively, and perhaps Germany, which is ramp up production of these tests early on. And that will allow you to do a better job of tracking cases and quarantining people who are actually effective. Without getting into why or how we didn't have that capability, say in the United States or in the UK, it's clear that we didn't have the capability to go and do the type of testing that would have been helpful in reacting to this. So saying how important testing is when you don't have tests is just, you know, it's a little disingenuous, I think.
And we didn't have masks either, so we told everyone masks were useless. But that's another controversy. But yeah,
Yeah, yeah, that's another issue, and you know that gets into. We can talk about some of the mitigations later on. Masks are definitely something we should discuss. You know, and
so
availability of
so
masks and supply chains and all that stuff.
so prevalence though, even asides of all earlier and whether or not testing would help, right now the actual probable prevalence of infected people in Europe and America, recent Italian data is talking about 38% of semi-random polls of people across 9 regions. Germany, I think you mentioned 15%. These are enormous percentages, maybe order of magnitude or more bigger than is being assumed in calculating death rates.
Yes, and if you look, so that gets into the model that we were sold, right? We can talk about the Imperial College model, which I've looked at a bit, and they projected a doubling of infection every 5 days, which works out to a 15% per day increase, okay? Which is actually, if you look at the data, that's actually a pretty slow rate of increase. When I did my analysis of the epidemic based on the Worldometer data in Italy, I didn't even put that line on my chart because it was a flat line across the bottom of the graph, a 15% daily increase based on their actual cases, right? What we saw is huge, explosive increases in Italy and other countries. Talking about, you know, daily increases of over 400% from one day to the next, you know, daily increases in the 50, 60%. So the initial reaction of the virus was just an explosive infection rate. And what that did, I think, is give us, and now, you know, to the prevalence discussion, these are only people, we're seeing this explosive increase, but in people who are sick enough to go to a hospital and get tested, right? The people who are asymptomatic or who can't tell it apart from the common cold or from influenza, which is what the symptoms are, we literally have no idea of knowing how many of those people there are, except to look at countries that have done pretty intensive testing like South Korea and Germany, and where, as you say, they are realizing. There was a German analysis that came out this morning that I haven't had a chance to fully look at today, but based on the data on prevalence in Germany, they're saying this virus probably had an initial R0, which is a number that helps you figure out what the daily percentage increase is going to be, of 5.7 rather than the, I think it was 2.4 that the Imperial College model was projecting. Now, to get to your point about prevalence and these mitigations, lockdown and quarantine is an effective mitigation when nobody's infected, right? I mean, it's, they knew this in medieval times. If the plague is around, you draw up the drawbridge and don't let anybody into your city. And, I mean, obviously, if you're not in contact with anybody who's infected, you're not going to get the disease. That's pretty basic. The problem is, if you look at those interventions, once you have the disease already in a population, especially a disease that's as infectious than this, it's just not an effective intervention. And that's what the literature shows, going all the way back to, I found a paper from not even a paper, a textbook on communicable diseases from 1948 that said, it just doesn't work once the disease is in your population. And we can get into why that would be the case. Unless what you can do is lock everybody down and have nobody go to the supermarket and, but practically speaking, we just can't do that. I mean, Wuhan got the closest to being able to do that, where they literally closed down the supermarkets and had people ordering food from the supermarkets, but people were going without food because of that intervention, which is kind of a problem to do in a free country.
But the key point is the effectiveness. The lockdowns we're seeing in the West are not like Wuhan. How much better are they if, per the Italian data released yesterday, apparently, and the German data, and even California, I think 8% of people with mild symptoms were found to have actual corona, and this is a little while back. If the prevalence is so high.
That was in February when they figured out that
Wow.
8% of the people, this gets back to my point about when did the disease get here? These were people who were coming in to clinics that were monitored by the CDC in early February, if I remember correctly, the first 2 weeks of February. And they were testing for influenza and testing for coronavirus, COVID-19. And 23% of those people were positive for flu. 8% were positive for for COVID-19 back in February. So yeah, it was effectively everywhere at that point, by that point, early February. And they didn't do lockdowns in March or in California until almost a month after that, because it took the CDC a while to turn around and get the data out, which is, another problem, but nevertheless.
So then look then, with an exponential increase and a doubling every X days, and we won't worry about the exact numbers, but obviously it's extremely rapid. And just for people to visualize, I used to illustrate with, if you take $100 bill and you say to someone, if you can fold that in half 7 times, you can keep it. And they all think they're going to do it. So they fold it once, twice, three, four, and then they find out. And if you had a dollar bill or $100 bill the size of a country, you still wouldn't get past 6 folds because it's so fast. So now we've got January for UK and America. We've got a tiny percentage of cases. Let's say it's the start, and Italy maybe was December or November. And then February in the US, like you say, now it's getting quite prevalent. And then by March, it's going to be pretty huge. So, any way you look at it, it's a huge prevalence before any lockdown. But the lockdown would be most effective when it's near zero prevalence, like in Taiwan or maybe Singapore earlier on.
Or South Korea, where
Tighten.
they're quickly
Yeah.
identifying people, locking them down, and then they don't even need to do a lockdown.
So a very late lockdown, and actually, I've been looking at the Sweden data versus Denmark, which I like to compare with, not so much Norway and certainly Finland. But you were showing, I think you were with Dave the other day, and I briefly saw you were doing an analysis of the changing tempo of this problem versus the lockdown point in Italy. And it was very interesting because it resonated with my intuition and what data I've seen. I'm worried that people will attribute benefits to lockdown that are not really due to lockdown. They're part of the natural order of this. So maybe you could share that data and look at kind of assessing lockdown in the data. How effective is it or not?
Right. So I started that off, as I mentioned, the Imperial College estimation was exponential growth of 15%. And their latest model predicts exponential growth to 7 billion infected people, which is 93% of the planet they're claiming will get coronavirus. Um, okay, do 93% of the people on the planet have any disease? Has anybody ever seen prevalence of a disease that high? I mean, maybe the common cold or influenza gets that high over the course of a lifetime, but it's not a credible projection short term. So my initial thought was that the virus was going to be a lot less, that their projection was going to be over aggressive.
It was the Oxford College team that made the point that it spread so fast, and with the early cases, looking at current data, modeling, and how these things work, they were saying in March, late in March, look, there's already probably 10 or 20 million people have it. They're just not symptomatic. So they were aggressive the other way, saying a massive amount of people have it, and the death rates are really very low. So they were the ones who got attacked.
And
Yeah.
if you look at the Italian data, you can infer that same thing based on what's happened in places where they've actually been testing, which is, I presume, what that German paper this morning did. So can you see this chart
Yep.
I've got up on my screen?
Perfect.
Okay. So the orange line are the actual reported cases in Italy. Now, again, as we mentioned before, this is not the total infected population. These are people who got sick enough to show up at a hospital and get tested, right? So if you're looking at prevalence, this orange line does not reflect prevalence. It reflects what you would call, in looking at an epidemic, there's two numbers, right? There's the infection rate, how many people in the population are infected, and then there's what you call the case rate, which is how many people are being treated, basically, at a hospital, let's say. So the orange line is basically the case rate, right? And what I
Yeah.
was really surprised, now again, the IC, the Imperial College projection was 15%. What I was really surprised, so the first thing I did was plot out the actual cases and then try and infer what the exponential rate of increase was to get to given points in time. So the green line here is projected total cases to March 9, which is when they did the lockdown. And to get to that point, that implies an exponential curve of 40%, right? 39.72%. So the initial infectivity of the virus was actually several times worse than what the Imperial College model was saying, right? Now, this gets back to our discussion of mitigations. If it's this explosively infectious, then doing a lockdown mitigation at some point in the future, you wouldn't expect it's going to have much of an effect because a substantial percentage of the population is already going to have it. So then I started doing this analysis on 327. So the blue line, I mapped a exponential curve to the actual number of infected people, actual number of cases on 327. And we can see that the growth rate has already declined to 28.25% per day, right? So we're still way over what the Imperial College model told us. But what we can see, but then, okay, so I was like, well, wait a minute, down to the before 3.9, the orange line is over the green line, which tells us that the rate of growth was actually higher than that 40%. So I got really curious to see what the trend was at the beginning of the epidemic, because that has an enormous impact on what happens later in the epidemic. So the next piece of the analysis that I did is I started looking at, now the green line, or the orange line here again is the actual number of cases. The green line is the 40% growth rate, and the blue line is the lower growth rate of 28%. But
Yeah.
the what we're looking at is the percentage daily rate of increase of the epidemic, of the case growth in Italy, okay? So, and you want to do this because you want to be able to see increases early on the same scale as later increases. So you can try and understand what the growth rate of this is doing, right? Because the Imperial College argument is this disease has an exponential rate of growth, and the interventions that you want to do are interventions that are going to, on a per day basis, lower that rate of growth. That's what flatten the curve means, right? So let's see if, so in analyzing that argument, you want to do two things. First, you want to make sure that their expectations about growth rate are correct, and they were incorrect. They were less, the actual increase was far worse than what they were projecting. But then when you start looking at this chart, daily percentage increases, it's obvious that there's an explosive early increase and then a steady decline daily in the daily rate of growth. So the next thing I wanted to look at was, okay, looking at the data, it looks pretty obvious that, it's slowing, right? And I marked, you see down on the bottom, there's dates on the bottom and then one date that's blown out, March 9, 2020, LD. That's the date they implemented the initial lockdown, the nationwide lockdown in Italy. And you can see on this graph, that date, there doesn't seem to be any effect on the decline in the growth rate in Italy. At least there's nothing obvious. And it's pretty obvious, just eyeballing it, that the decline started almost immediately after the initial spike. So that was the next thing I wanted to do, was look at some trend lines in the data. I truncated the chart a little bit because the 425% increase was just, as far as I'm concerned, a data aberration. I did one analysis where I started it at 225 to get rid of that, and I pretty much came up with the same curves. So I included all the data in my second analysis just so that people couldn't critique me for, not including everything. So again, what we look, the orange line are the actual cases. The green line is the percentage growth rate, which is flat at 40% and 28%. And then the green line is a logarithmic trend line, and the red line is a 10-day moving average. And again, you can see long before they did the nationwide lockdown, there's a clear and steady decline in both of those curves, right? And there's no apparent change in the rate of decline of the spread of the disease after the lockdown. Now, this was really surprising to me because I figured it would have some sort of obvious effect, but maybe it wouldn't be enough of an effect to make it worth doing. But looking at this, you don't see any obvious effect of what's going on here. So then I thought to myself, sorry, go ahead.
Oh, yeah, and if anything, as this is progressing, there'll be, if anything, more testing and more focus, which would keep the figures higher, maybe artificially. But even notwithstanding that, the trend is almost oblivious to the lockdown in a sense.
Yes, the lockdown doesn't seem to have had any effect at all. And so anyway, so then I started thinking to myself, okay, well, maybe this, because of the testing problems, we're missing some number of infected people. Go ahead.
Yeah. I'll ask one question before you move on, because I know you're going to move on to mortality, a more powerful figure. But here, there's going to be a lag anyway from lockdown to testing being done and picking up people. So that lockdown point you're showing here, like the trend with no lockdown effect, you can continue in your mind's eye well beyond the lockdown point. So it even further reinforces this trend was going down, down, down with no lockdown effect.
Right. So you would expect the median rate of incubation for the virus is 5 days, meaning basically half of the people who are exposed to the virus and who get an infection are going to become symptomatic after 5 days and be testable after 4 or 5 days.
or
So
more.
you,
Yeah.
or more, well, I mean, that's a median. So you would
Okay.
expect to see a change in the data after 5 days. And if you go out 5 days, the trend line really doesn't change all that much. And that's even
Yeah.
more, now that what you just brought up is even more apparent and more important when you start looking at actual mortality. So let's go back. I did the exact same analysis for mortality. The black line is total deaths from Italy. The blue line is projected total deaths to 3.9, which is 40%. The green line is projected total deaths to 327, which is 28%. Now, what's really fascinating about this, in terms of doing an analysis and trying to evaluate the actual cases data, is that these trend lines are almost identical to the actual cases data, which tells you that there's a pretty solid relationship between people who show up at the hospital and get tested and show up in that orange line and people who progress to death, right?
Yeah.
It's an argument that that orange line is a pretty solid number when you're trying to do, even though it's not capturing all the people who are infected, it is a solid population of people who are infected and experiencing some degree of serious disease. So again, same thing. I've got the March 9 lockdown number blown out on here so that you can see. And again, it's really hard to see. It looks, eyeballing it, like the black line is tracking a 40% exponential growth rate until the lockdown. And then after that, it starts to diverge. So again, the next thing I did was look at the percentage daily increases, mapping the green line here is the 40% number, and the blue line is the 28% number. And the black line is the daily percentage increase in mortality. And, again, what you see is what seems to be the pattern for this disease, an explosive early increase. It's very noisy, it's going up and down, but it's tracking at, frankly, a very scary rate of increase. It's tracking between my 40% and my 30% growth lines until the lockdown. And on the day of the lockdown, you can see that the trend seems to be petering out, that the rate of growth seems to be dying off. So again, I did the same thing. I threw in some trend lines. The green is, in this case, a polynomial line, which was the best fit to the trend, and the red is a 10-day moving average. And here you can see pretty clearly that a downward trend seems to be in place a few days prior to the lockdown and continued immediately after the lockdown. So now, as we were discussing before, and I listened to a podcast this morning with Professor Kentaro Iwata on the Paleo Canteen podcast, and he discussed how you would analyze effectiveness of interventions like this. And he pointed out that there's a lag time, right? 5 days is the medium incubation period for the virus. Then I think, medium intervention to getting serious symptoms is another 5 days. And then you're going to be in the hospital for a few days before you die and appear in that black line. So if you do an intervention, you wouldn't see a change in the black line for at least 10 days, right? Which is why I'm using a 10-day moving average here.
I think you're being fair there because I'm not sure of the figures, but from going into the hospital and that, you're saying 2 or 3 days maybe till actual death. But I suspect it's longer than that to actual death, what with all the ventilator and all the processes. So let's say 15 days is probably a fair minimum after a lockdown to see a death impact.
Let's be even more conservative than that. Let's not take those days into effect at all. Let's just say there's a 10-day lag time, okay?
Okay.
So you don't see a lag time here. In fact, it looks like the trend has changed before the intervention went into effect, right? What we should see is a 10-day, this number changing. If the flatten the curve claim is correct, you should see the curve changing 10 days after the intervention. 10 days out after the intervention, they're already in a steady decline in the growth rate, right? So, you know, if the change occurs before the intervention didn't cause the change. You don't need to be a medical doctor to know that. That's just basic causation, right? So now what I will point out, though, is the growth rate was terrifying up until March 9th, which happened to be the date they rolled in the lockdown. And you can imagine that the politicians in Italy are looking at this terrifying increase in deaths over there, and that's why they implemented the lockdown, right? I was quite surprised to see that in the data so clearly. But you're just not seeing an effect of the lockdown on the disease progression over there.
Now, the surge that scared them so much, there's an element of natural expectation there that it's very virulent, it's spreading like hell, and the recent data, as we talked about earlier, is beginning to suggest that vastly more people have it than they thought. And what will happen is it'll spread rapidly, and then it'll hit the most weak populations and nursing homes and all that kind of thing. And then you're going to get some kind of a big hump in death following that. And I think you're kind of showing the hump there. And then I guess with no intervention, the hump will begin to fade at some point. Why does the hump fade, given that the intervention didn't cause the fade in death? The hump reaches a peak and then fades naturally.
This could just be the normal course of the disease. It's got an explosive early growth rate, and then it's harder for a virus to spread once it's in a population where a lot of people have been exposed to the virus, right? I mean, that's the herd immunity that we hear about. Unfortunately, let me get to one more piece of data that I think it's important to look at to understand what's going on here with the Italian. So here we have Italy in black superimposed above a bunch of other countries showing the daily death tolls, right? And now we saw from looking at the data in Italy that cases tracks pretty closely to death tolls. So we're just going to assume that that is true everywhere. And what we see is there are two big outliers. There's China, this orange line, and we're not gonna get into the situation in China because there are too many questions about whether or not they're accurately reporting data for it to be worth discussing. And then there's South Korea, right? And then a couple other little countries well, not little countries, India is a rather big country, but what you see is that Italy is in the middle of the pack as far as how this virus is spreading, right? They've got a steadily decreasing growth rate. The Times kindly put little black stars on all the countries that have a lockdown. And what you see looking at this chart is, with the exception of China, there doesn't seem to be any major difference. I mean, if the lockdown argument is valid, then you would expect to see two clusters of lines here. A cluster of countries that doesn't have a lockdown or has an ineffective lockdown, and then another cluster of lines that has a stringent lockdown. And then we would imagine poor South Korea down here that didn't bother to do a lockdown at all, but actually did an effective response to the spread of the virus. But that's not what we see. We see them all bunched together right there in, there doesn't seem to be any impact on whether or not you've done a lockdown, looking at the data here.
Yeah. Which aligns with your earlier analysis, pretty much. Does it also align, though, historically, and you may have mentioned this already, that historical literature, even in polio outbreaks you mentioned, that once you've got in the population the virus is pretty much out there, the lockdowns have very limited effect. But if you lock down prior to the virus getting in, sure, you can hold things off.
Yeah, that's exactly right. And it makes perfect sense. I mean, if you've got a super infectious disease, if it never gets into your population, it's not going to spread, right? But once it gets into your population, and since clearly we're looking at the clearly what we're seeing is this disease spreads explosively once it gets into a population, far worse than was initially projected. It unfortunately just makes the lockdowns that less likely to be effective. And if you look at, I found again a paper from the Journal of School Health of all places titled "Should Schools Be Closed in Times of Polio?" Their conclusion was, and let me point out that polio is a far more serious disease than coronavirus is in terms of what it does to people, and was also an annual epidemic in most industrial countries up until the polio vaccine came out. They didn't find any difference in efficacy between places that did lockdowns and places that didn't do lockdowns. So now one other point that I want to make here is let's look. One of the claims that I've heard from people is that, oh, well, it's just Italy. And, I addressed this at the end of my post. And it's a fair point, right? Because they're going to say, oh, well, Italy didn't effectively do a lockdown. Okay, so fine. So we can check that. The Italian press talks about, the streets of Italy being empty after their initial lockdowns, and apparently they've arrested, as of the time of the news article that I was looking at, 40,000 people for violating the lockdowns, which is far more stringent than what I've heard any other place. There's one guy who apparently had elective surgery while he was infected with coronavirus, and he's looking at a 2 years of prison time once he goes through his trial. So I don't think it's fair to say, without some evidence, again, that the Italians didn't take this seriously. Now, Google, we all know Google Maps and probably Waze. Google gets the data that feeds those applications from their cell phones, from the Android operating system. So Google has an enormous amount of data on how people travel around, right, and where they go. So what Google just released a service that showed how effective lockdowns are on different populations, right? So the first thing I did was I'm in Connecticut in the United States, was look at how effective the lockdown was here. And then I thought to myself, well, wait a minute, what about Italy? Well, sure enough, they have data for Italy, okay? So what does that look like? So here's a snip from the PDF looking at mobility changes in Italy, right? And what you see is retail and recreation down 94%, grocery and pharmacy down 85%, parks down 90%, transit stations down 87%, workplaces down 63%. Now in Connecticut, the workplaces number, which I think is probably the best indication of how seriously a population is taking lockdown. In Connecticut, it was down 38%. So the Italians are taking this substantially more serious than Connecticut, where I am, where the roads are empty, basically, during rush hour nowadays. I mean, it's spooky. And residential was up 24%. Here in Connecticut, it was like up 15%. So based on the data, the Italians are taking this lockdown extremely seriously, far more so than any of the communities in the United States I looked at which was mainly Connecticut and California.
Yeah. And there were reports on that when the lockdown started. I mean, there was no question there was elements of civil unrest and people not getting food, and there's no question, but Italy, with that surge that they had, they got terrified and they did a massive lockdown. And it was as severe as you're going to get. So the Google data just makes sense. Yet still the prevalence and indeed the deaths rolled on downwards, trending with no change given the lag time that you described. So far we have an absence of data for lockdown efficacy. Um, And the data in Sweden and Denmark, I won't share it right now, but again, so far I would say a lack of evidence given the lag times. And the nat
Let me make two quick points there. The first one is the fact that Italy went with lockdowns. They were the first non-Chinese communist country to go with a lockdown response. And the fact that they did it was basically gave places like the United States and England, Great Britain cover to do it. Obviously, it was done without evidence of efficacy, because we can look at it now and see that it doesn't seem to be efficacious, but it did give the politicians cover. And we know that when it comes to using evidence to guide policy, politicians, especially in a time of panic, aren't as diligent as we would like to be. What's disappointing is that a lot of public health professionals also don't seem to be as diligent as one would like to see in evaluating the efficacy. Professor Iwata, the Japanese infectious disease specialist, says right off the bat, right, exactly what you can determine from looking at the data in my analysis, that a disease that it spreads explosively right on is not really a good candidate for a lockdown, because it's going to get into the population. And that's great, it's going to get into the population, it's going to spread throughout the population. And then at that point, it's the old, you're closing the barn door after the horse is left. And it looks like the horse is long gone in most of these cases.
Now, the horses left, or indeed, I suppose, myriad horses have gone off over the horizon between January first cases and end March when lockdown started. I mean, endless horses are gone. So what are you stopping? And what really annoys me are people say, "Oh, people can't just go about their business. It's the crisis." Well, no one's saying go about your business versus lockdown. The thing would be, if anything, the discussion is masks, hands, distancing, and all of that stuff versus lockdown. That's the only compare I'm interested in. Really smart mitigation, minimization versus full lockdown. That's my compare, and that's all I've talked about for the last couple of weeks. So Sweden is an example. They went with kind of distancing, protect the over 70s, makes absolute sense. More isolation play there, but they had a very soft, smart system. I mean, I think they should have added masks and a lot more stern instruction and separation, maybe, to get a really good mitigation. But either way, it's stuff like that versus full lockdown is my interest.
Right. So let's
And I,
look at that.
because, and just to finish on that, it's not about just doing what you bloody want versus lockdown. That's a false comparison and very frustrating. It's about doing really smart mitigation with masks, cleaning surfaces, hand washing, managing stores like in Ireland, where people come in blocks for a period. And as people leave, more are allowed in, distancing, all the smart stuff versus lockdown.
Right. That's right. Although even some of that gets a little too onerous, right? Is it really necessary to maintain 6 feet of separation if you have a mask on, right? And you look at a city
True,
like,
but let's say freedom protecting, or sorry, let's say freedom protecting and rational measures versus lockdown. And that would mean maybe if you've got masks, it can be 1 meter. Maybe you could do 2 meter anyway. Let's say smart mitigation versus lockdown, and that will include all the nuances you mentioned.
right. So I plugged Sweden into my little model here. Sweden, as you were just mentioning, has done a standard evidence-based intervention for the coronavirus, which is most businesses and schools stay open from my understanding. I mean, I don't speak Swedish, so I'm not reading a lot of Swedish papers, but that's what I've understood. They're explicitly not doing a lockdown, and they're taking a lot of heat for not doing a lockdown. Sweden and Italy are obviously very different countries. Sweden, I've never been to Sweden, but my understanding is it's a lot rural, which one would expect would slow down the spread of an epidemic, because density is definitely a factor, especially obviously in a respiratory disease. So I plugged in, again, the orange line are actual cases in Sweden. We won't get into testing questions over there. The green line here is just so that we had an apples to apples comparison. Again, goes through their total cases on March 9, and that is an exponential growth rate of 26%. Well, in Italy, that was an exponential growth rate of 40% to March 9th. So then I added in the blue, I figured out the exponential growth rate to 4.5, April 5th. And we're looking at a 19%, call it 18.9%. In Italy, to 327 was a 28 and change percent growth rate. So spread has been much more moderate in Sweden than it was in Italy. And again, if you go all the way over here to the trend lines, you see a similar pattern. You see explosive early growth, and then it starts dying off immediately. Here, there's no lockdown date, obviously, because they have no lockdowns. But you do see a pretty similar pattern. Now, I will point out that when you get into the out periods, the trend line seems a little flatter than the decline in Italy. And maybe that's just because they're not as far along in the epidemic as Italy is. Or maybe that's the difference between Sweden and Italy because of the lockdowns, that, maybe that's where they're flattening the curve. They're going from 6% to 4% daily increase in cases. That's possible. I also plugged deaths in. Deaths are really scary in Sweden. It tracks almost perfectly to the exponential growth curve of 26.7%. But deaths in Sweden started a lot later than they did in Italy because the disease got there later. Again, you see a really noisy line, and the trend lines, the log trend line is going up and the moving average is going down. So I expect at some point the log trend line will start going back down again. So you're seeing kind of a similar position. This sort of looks like the data in Italy that we saw right when they implemented the lockdowns over there. But even then, it's actually very similar to, because if you imagine a 28 and a 40% rate of growth on there, clearly they're bopping between that, and they're maybe a little slower than what's going on in Italy, which again could be, a lockdown isn't going to affect, obviously, how many people progress from being a serious case to a mortality. But so this line isn't necessarily at this point going to be reflective of that. And the difference between serious cases and deaths isn't going to be reflective of a lockdown in this model. It's not really going to move those numbers. So yeah, to the simple people who say, oh, look at Sweden, Sweden's better than Italy. It's not worse than Italy. And there are a lot of reasons why Sweden and Italy are going to be different. I mentioned a couple, but to the people who tell me, oh, Sweden's worse because they don't have a lockdown. No, Sweden doesn't have a lockdown, and they're better.
Yeah, and we might look at I became very interested, obviously, in Sweden. Well, because I like the Swedes, and also they're creating a control group, which is very important in an intervention that has no proof or basis. So I'll just share here um, just a glance at Sweden, and I was just trying to illustrate to people that there's more to it than just the numbers themselves. You got to think about lag periods and all. But I was interested in the geography and the density and demographics. And I like comparing Sweden to Denmark because Denmark has 5 million people, Sweden 10 million. And there's a concentration down in this area of Sweden, obviously. And Denmark and Sweden are connected by a land bridge. And there's huge traffic over the months between the countries. So Sweden, 10 million people, not in this spot, but all of Sweden. But you can see the density versus 5, and the normalized death rates are 68 for Sweden, 38 for Denmark at last count. Not a huge difference, right? And then Norway, I'd compare less because it's 5 million, but they got the concentration of people on the western seaboard, and it's a different kind of country, and we don't know the spreading dynamics or where they are in their sequence. I mean, 5 days behind will make a huge difference because of the exponential rises. And Finland out here is doing very well. But then again, look at Finland. It's completely geographically separate and quite sparse. So I'm trying to tell people, if you're an escalation or crisis manager, you can't just be looking at curves. You got to be thinking of all the context, every single dynamic, and include all of this stuff. And then if you look overall at Sweden versus other countries, I haven't even shown Italy because it's so high, I just left it off. But to your point, we have France at 167 per million, Netherlands 131, they're pretty dense. Sweden 68, Denmark 38, Ireland 48. And we're considering that we're doing great. But I mean, Ireland is like doing great. So the next week or two will say a lot when the lag post lockdown actually becomes a reality and you can begin to truly judge the measures. But the other point I have to keep making to people is it's infuriating. It's so high. It's through the roof. It it's up here with Spain and Italy are so high in death rate per million that they're off the top of the chart. I only fitted in these.
Okay. Do you remember what the number was for Italy?
I don't, but I just remember it was a bit ridiculous, and Spain as well is terrible. So Italy, let me see. Italy is 300 per million death rate. Spain is 326. Belgium is 218. France is 167. So if we go back to uh, our model here, yeah, up in the 300s for Spain and Italy and 200s for France. So off the top of this chart.
Right. And as you said, it's not, since the disease started earlier there, it's really not good to compare just the raw numbers.
Yeah, not really. So these ones I figured were a bit more comparable.
Right. No,
So,
that makes sense.
yeah. So we basically have then that, Sweden, the jury is kind of out, but to be honest, I would have expected to see something more by now. And also, I'm acknowledging that Sweden has a very soft distancing strategy. So I would have liked to compare masks and a tougher but still freedom protecting strategy. But Sweden have gone very soft. But I guess that makes them an even better.
Exactly. It makes it an even better comparison because you're looking at a worst case lockdown intervention, right? They're not doing apparently as good a job as, say, Italy or, the United States is doing in terms of implementing a lockdown, and they are
Or
not
UK.
catastrophically worse, right? Which we've been told. I mean, the growth numbers, what was the Imperial College guy claimed that the UK was going to have 500,000 deaths. And then he said, oh, well, I'm changing that number to 20,000, which is like twice the normal flu mortality because the lockdown has been so successful. But when we look at the country that isn't doing the lockdown, there's no difference. There's no, I mean, that's a 10 times worse or whatever the number is. I'm horrible at doing math in my head, but 500,000 versus 20,000, that's an enormous difference. We should be seeing that difference if it's actually
Oh
going
yeah,
to happen.
yeah, it's whatever, 20 times. It's order of magnitude plus. But we're now seeing a comparison between lockdown and just smart distancing, a soft version. But again, another week or two, this will really bear out. The other thing is Sweden has other reasons. So I showed the demographics and the geographics, right? They're two things. But there's other reasons too. Sweden apparently got hit pretty hard in nursing homes and older, being a high proportion who got it. So that's another factor. of looking at country comparisons. So in a week or two, when we start looking at it all, um, I suspect the lockdown is a very weak intervention given its cost. I'm not saying it does nothing, everything does something. And I'm not saying people shouldn't be careful. I think they should be more careful than they are now. I think they should be using masks more, cleaning hands more. But all the stuff that allows us to continue to operate and that's smart. So the cost of the lockdown, Tucker, maybe let's look at a bit of the cost. You're an economics guy and Wall Street. I'm not an expert on this, but this is unprecedented.
Well, yes. I mean, you think it's hard to get decent number about the disease. Try and get some number on the cost of the uh, lockdown interventions, precisely because it's never been tried before. Um, the best comparison to, one could argue, the best comparison to today's situation is the 1918 flu epidemic. Um, there was no GDP calculation back then. There was virtually no tracking of economic activity. I found a paper from one of the Federal Reserve banks looking at the economic impact of the 1918 flu. And, you know, they had very little data. They were basically reduced to the Federal Reserve had only been started, I think, in, when was it? 1916 maybe. So by 1918, they weren't doing nearly what they're doing nowadays, obviously. So they were basically reduced to going through the libraries of the different Fed banks and looking at newspapers from the time. And what they found was, you know, there was a substantial impact on businesses, right? It was 50% declines in revenue, blah, 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 you know, lots of people laid off. But it wasn't, it also was a area specific intervention because there was no national lockdown. So, you know, a city that had a high rate of infection, people wouldn't go to the store. You know, interestingly, back then, one of the businesses that took a real hit was supermarkets. People weren't going to the store. So, and not because they were told not to go to the store, because everybody knew that it was a respiratory disease. So people, shockingly, without being told, people did sensible interventions.
They were smarter back then.
Well, in some ways they were smarter back then, unfortunately. So there were. So it's really hard to say what the effect was. Clearly, there was a huge effect, but it also ended really fast because, you know, it was again a city by city problem, and it wasn't a nationwide problem. And they did, you know, I mean, there were an enormous number of deaths back then. So, you know, I want to be hesitant about saying they bounced back quickly because obviously those people could never be replaced, but the economy bounced back pretty quickly. There was no Great Depression after the 1918 flu. You can say that with certainty. In fact, what we had was the Roaring Twenties.
Yeah. And what about 1957? I only discovered a couple of weeks back. I never heard of that. 1.5 million dead around the world. Big deal in America. A ribovirus, same as this, pretty much. And it killed young people under 20 and under 15. So even more tragedy. But also there was a huge tail for older and sicker because that's a standard with these things. But the 1957,
Yeah, there's no way. Where was the Great Depression of 1957? You know, it bounced back pretty quickly without these lockdowns. But unfortunately, a nationwide lockdown. So I found two economists who were discussing this. One was a Kevin Warsh, that's Warsh, who's a retired Fed governor at the Hoover Institute. And he was talking about bouncing back from this. And he compared this to the financial crisis of 2008. Okay, so in 2008, the decline in consumer purchasing, and that was one of the worst financial crises in the world after the Great Depression. I think it was the worst after the Great Depression. The decline in consumer purchasing was 3 to 5%. Okay, the decline in consumer purchasing currently is 40%. So it's more than 10 times worse than 2008. And he said the big difference between then and now is this decline is the result of government action. It's self-inflicted. I'm assuming based on 1918, there would be an effect because people are going to go out less and they are going to avoid going to crowded venues regardless of what, I mean, what I saw was all the ski resorts closed before any lockdown orders because all the skiers stopped going because they didn't want to be in crowded areas, right? People get, the intervention for coronavirus, it's important to note, is no different from the intervention for influenza, right? Wash your hands, wear a mask, stay away from people who are infected. We all know how to do this and what to do. It's just people are taking it seriously now, whereas in a regular flu season, they really don't.
And protecting the elderly, of course, is a classic for influenza.
The flu, everybody knows that. Or at
Yeah.
least everybody I
Now,
know that. So
yeah.
then we had Robert Barrow, who's an economist at Harvard, who wrote an article where he projected a 20% decline in GDP, right? 20% decline in GDP lets us put some numbers onto what this thing is costing us, okay? This is in the United States. Sorry for being so provincial. But a 20% decline in GDP in the US, GDP is $19.7 trillion. 20% decline is $3.8 trillion, trillion with a T. And just to put that into comparison with some number that everybody will understand, healthcare, the entire healthcare spending in the United States is $3.6 trillion. So effectively, what we have chosen to do is spend an amount equal to the entire healthcare budget of the United States for 1 year to fight this pandemic, which starts getting you really quickly into a risk-reward analysis, right? And makes you want to start asking some really hard questions about the damage that we're doing to the economy. Because we're not, hopefully if we decided to lift this tomorrow, the economy would bounce back pretty quickly. That's actually an excellent segue. Let's talk a little bit about what this intervention that we are in the middle of actually entails. Because I've talked to a lot of people who say, oh, a 2-week or a 1-month lockdown isn't that big of a deal. You shouldn't be so worried about lockdown. And I agree. A 2-week or a 1-month lockdown, assuming it was effective, would be a perfectly reasonable thing to do in light of this, right? But the lockdown that the Imperial College model says that the lockdown should continue, not for 2 weeks or a month, but 18 months or until a virus is developed. Right?
Or a
So
vaccine.
yes, sorry, a vaccine is developed. Yes, thank you. 18 months, right? Anthony Fauci, I forget what his position is, but he's the guy who's standing up there with Trump all the time in the US, has said the same thing, that the intervention needs to continue until we have a vaccine or useful treatments for this disease, right? There's going to be very little left of an economy put into this state of lockdown after 18 months. I mean, you're looking at entire industries like the airlines, which I'm kind of partial of, gone. The restaurant business, gone. And one can go on and on and on. Movie industry, television, all of these businesses will be gone in 18 months. And there's simply no amount of government spending that is going to enable all of these businesses to survive. Because at that point, you're looking at, the government just printing money, which gets you into, great, will be Weimar Germany or Venezuela in 18 months.
But on that point, the 4 trillion approx, which is more than the whole US budget for healthcare, what fraction of that could expand the specific healthcare needed for this virus? If it's 4, 5 times worse than the flu, you need a couple of times more capacity or 3, 4 times more capacity. So, what about the bottleneck that is causing the crisis, i.e., the medical care? That bottleneck is the only thing that causes extra deaths over what would occur anyway. But that bottleneck, surely a fraction of the losses that you're describing could pay for that bottleneck. And then there's even the question over ventilator efficacy and how many people it really saves as a percentage. But it doesn't seem to make any sense. The other thing I was wondering is I assumed all along there's no way the lockdown can go on longer than a month or two. That the virus is 12 or 18, or sorry, the vaccine is 12 or 18 months away. And by the time we get to the vaccine, we inevitably will have moved beyond this to a large degree. Inevitably, and then the vaccine then will be partially effective, like all vaccines for these type things. It's always been a massive challenge to have a vaccine that's more than X% effective, and then there's mutation. So I couldn't understand the logic of the vaccine being the savior.
Well, yeah, that's a bunch of great points. Let's get into that pretty quickly. The United States, I looked at the healthcare budget in the United States versus deaths, just because, it's kind of hard to come up with a metric. So what percentage of the total healthcare budget is spent on preventing deaths? Flu deaths, it works out to about $1.3 million per flu death, right? If we were going to have 2.2 million people dying in the United States, then spending all of our healthcare budget trying to prevent each one of those deaths would get us up to about $1.7 million per death, okay? But it doesn't look like we're on track to get to 2.2 million. It looks like we're on track to get to a much lower number. If you look at 100,000 people dying from this, which is about twice the mortality of a normal flu year, we're talking about spending $58 million per death, which is an enormous number. And Malcolm Kendrick, a British doctor, went through an analysis looking at what it means in the UK, a much better one than what I just described. But he still comes to, okay, we're going to be spending 10 times what we normally do to prevent each one of these deaths versus something like the flu.
Yeah, and he actually, rough and tough, I talked about this earlier, and it was a great analysis. He was saying we can all get emotive and talk about, oh, the dead can't speak, and you can't compare the dead against economies. Of course you can't, but we're talking about a logjam in medical care capacity is the only thing that causes extra deaths. That's the first thing. And the second thing is the UK and other countries for decades have been putting a value, with limited resources in healthcare, a value on human life. They have to. They have to. And he had that they are willing to spend up to 30,000 sterling per quality adjusted life year saved, which is reasonable. And conservatively with this, it'll be 300 grand, 300,000. But if the data coming out of Germany and California and Italy, if the death rate is much lower, based on it's already out there hugely in the population, it could be 3 million per quality adjusted life year or more. But no one's thinking rationally about this. Everyone seems to want to wave their hands and scream. And I find it a fascinating phenomenon, with all due respect to the tragedy that's occurring. Of course, it's a terrible disease, absolutely. But in Sweden, 26% in an analysis were scared of it, and they have the most lax controls. In Malaysia, I think it was, they have severe lockdown, and 92% are scared of corona. So it almost this, yeah, the psychiatrist doing the analysis pretty much was kind of saying it looks like the amount of fear and upset about this is in proportion to the severity of media government response rather than actuality.
Yeah, there's clearly a promotion of panic by the authorities, which is despicable, especially when it's by people who, like Anthony Fauci, who I'll single out because he's the tip of the spear here in the United States. Um, so let's get into the intervention a little bit more, just so people understand what the plan is. The plan is not a 2-week, which we're past, or a month, which will almost be at lockdown. The plan is a lockdown until further notice and maybe forever, right? Yes, Fauci himself has said that we cannot, we can't relax these measures until we have a virus or a vaccine again, or some reasonable treatments to this. Okay, so that gets you into how hard will that be, right? And it also gets you into why do they think the lockdowns have to continue for so long? Well, all of these models, so the fellow who did the Imperial College model did an analysis a few years ago of the 1918 flu. And what he saw there was that while lockdowns, which were done on a city by city basis in the United States at the time, as we mentioned, had a short-term efficacy, as soon as you release them, the virus came back, right? And they didn't see a significant effect on reducing total mortality through lockdowns. The same analysis was done in Japan, looking at schools. Again, it just comes back later on if you have a short-term lockdown. That's why they're proposing a perpetual lockdown, because they've seen already, it's built into their model that a short-term lockdown is ineffective in containing the spread of the disease, right? That's what flatten the curve means. It means you are putting off serious disease and deaths that would happen now into the future, but you're not preventing them necessarily. At least that's what their model assumes, right? So built into the assumptions of their model is that it has to be perpetual if it's going to be effective in saving lives, because they have to wait until there's a treatment, okay? So that's fine. We can agree or disagree with that, but then that gets us into the next step of the analysis. How likely is it that they're going to be able to find a treatment? Because if they can't, then there's, there's no point in a perpetual or a long-term lockdown that's going to have an enormous negative impact on all of the people who don't actually have the virus, which is, let's face it, it's what they're doing. They're doing harm to people, right? Somebody who goes bankrupt, which is going to happen to a lot of people, and loses his job and can't afford to feed his family, you're doing harm to that person. His risk of mortality goes up, his risk of suicide goes up, his family may break down, there's going to be long-term consequences on the children. This is not a trivial intervention that they're doing. And I mean, people like to just say, oh, but that's not, preventing people dying from coronavirus can't possibly be the only thing that we care about anymore, right? We have to care about everybody. So, okay, so the lockdown's going to be perpetual until we get a virus. Fauci said,
Vaccine.
God, I need to stop doing that. Fauci said 18 months to get a vaccine. Okay, let's look at this virus, okay? They call it the novel coronavirus, right? Coronaviruses were first discovered in the 1960s, okay, as causing respiratory infections. The data from the 1960s tells us that coronaviruses are highly contagious and can cause serious disease in populations, and they are endemic in the human population. So one study I found from the 60s said that the population prevalence of coronaviruses was like 40 to 50%, right? So huge. It's an incredibly common virus. It's the primary cause of the common cold. 20% of people who have the common cold have it from a coronavirus. 20% of people who have an influenza-like illness have it because of a coronavirus, right? So Yes, this specific virus is novel, but the class of viruses are not novel. And just like, the 1918 flu was far more fatal than the average flu, but we still call it the flu. I think we have to look at this virus in the context of its cousins, right? The coronavirus is so similar to the common cold virus, which, just like with influenza, right? Just because I call it the common cold doesn't mean we can't have the same distinction between the 1918 influenza and the regular flu that you get and you don't worry about, right? This is clearly a worse sort of common cold, but it's so similar to the common cold that there's actually cross immunity, right? If you have antibodies to the common cold and have already been exposed, you are going to have a much faster response to the coronavirus. There's cross reactivity between the two. It's so similar to the SARS virus that SARS being the 2003 virus that went around mostly Asia and a little bit in Toronto. It's so similar to that virus that they seem to think that a vaccine for one would be effective against both, right? So it is a distinct virus, but it's not so novel that we can't analyze it in light of the other viruses, right? Which lets us start looking at some things, right? So, okay, basically they're telling us now that it is so similar to SARS that a vaccine against COVID-19 would probably also be effective against SARS, right? Well, that's an interesting piece of information because back in 2003, there was a guy who started looking into creating a SARS virus, okay? Anthony Fauci, is now saying it's going to be 18 months to a vaccine for this, to a SARS vaccine, effectively. Anthony Fauci started working on a SARS vaccine in 2003. So he's been working at it without success for 17 years, right?
And
Do you
I heard in
we're going to finish it in 18 months if they haven't been able to do it in the last 17 years? I don't think it's credible. I just found a Chinese paper where they kind of said, okay, here are all the list of all the problems with creating a vaccine for this. And the notion that we're going to finish this in 18 months is extremely optimistic, which is a pretty kind academic way of saying, no flipping way is that going to happen, right? As
and
far as treatments
I think
for it, this is, it's a more severe common cold, but it is a common cold. The symptoms are the same as what you get from a severe common cold, which can kill you. I found an interesting paper looking at a nursing home who are obviously very, as we've discussed, prone to these sorts of things. And they found an 8% mortality rate over 4 years in the nursing home from the common cold, from a coronavirus. Waiting for a vaccine for something we've been working on for 17 years already and trying to come up with treatments for a disease that we've been treating for decades because it is, the common cold's second cousin. We're never going to get out of this lockdown if we wait for those two things to happen. It's just not a plausible strategy to pursue. It's not a credible strategy to pursue.
yeah, it will begin to resemble pretty quickly a scorched shirt policy, where the both sides of the ledger just don't make sense. I'm guessing. So you know what? We might wrap up then with that last topic that was in the back of my mind was again this thing that it's a medical system capacity issue more than a virus issue in ways. If we had plenty of capacity, then we would be working through it. Essentially, I mean, I'm sure that's what the world would decide. It's terrible. We've got a lot of people, mainly older and sicker, who are dying, and they'd be looking for prophylactic, they'd be looking for medications and stuff. But it wouldn't be so much vaccines because we could handle and care for all the people. Uh, but this recent controversy around the ventilators, that this virus, one thing that is different than the common pneumonia type influenzas or colds, is that apparently it's affecting the heme or the iron in the hemoglobin and causing hypoxia, lack of oxygen, without actually causing problems with the muscle of the lungs. So there's an emerging thread that the use of ventilators using a lot of pressure could actually make things worse in ways, and they should be using more oxygen rather than pressure in the ventilators. And maybe one of the treatment improvements that'll come out is they'll be optimizing the use of that equipment, and perhaps they'll, in doing so, release some of the backlog, or sorry, the clogged system of equipment availability. So maybe we just finish on that one.
Let me say, I'm not a doctor, and I really don't know the ins and outs of how they're treating people. I mean, I've heard about ventilators, and I'll point out that the shortage of ventilators initially was a projection, and that the actual use of ventilators has fallen. The actual requirement for ventilators, even in places like New York City, has fallen far short. Like, you know, I don't want to throw out a number here but you know, you can go look and see that the actual ventilator use is far short of what it was projected to be. So I think, again, anybody who's worked in modeling, you know, in technology or on Wall Street in investing knows that you never believe the model, right? The model's only as good as the assumptions and the data that go into it. And what looks to have happened here is that we had some guys who, to be a little harsh, were doing rookie modeling efforts and weren't correctly analyzing what was going on. And then we had some even worse than rookie modeling customers, being, you know, a lot of the politicians who saw these scary looking charts and freaked out over it, right? Governor Cuomo here in New York is having to walk back a lot of his early reaction to this, including saying that, you know, if he had time to think about it, he probably wouldn't have done a lockdown. Oops. So yeah, there's definitely an issue with being able to treat people, and the hospitals in New York City, regardless of their state, a couple of weeks ago, are now full and stressed. But we still have an enormous amount of hospital capacity in this country. I mean, a doctor from Yale New Haven, which is an hour and a half drive from New York, wrote an editorial in the New York Times the other day saying how empty they were, that they've got 300 COVID cases, and their beds, they have more empty beds than at any time in their history. They're an hour and a half from New York City. So, you know, I mean, to make a fairly harsh assessment here, if it's serious enough, this guy should get on the train and go down to New York City and be treating patients. Or alternatively, probably what makes more sense is New York City should be sending patients up to New Haven, where they've got excess capacity, according to this guy. So, you know, it looks like the curve of the virus is a lot less than the forecast, which is not hugely surprising when you start looking at some of the early numbers that were coming out of Korea and from the Diamond Princess cruise ship, that mortality was, you know, a tenth of some of the initial projections. It's not too surprising that one should go back and say, okay, these initial projections were way off base, and it looks like it's a much, much less severe disease than we were initially projecting. I don't know what's going to happen with ventilators and treating these people. I mean, you know, hopefully they pretty quickly figure out effective treatments, because it sounds pretty dreadful once you get to that point. And I will mention that I have been under lockdown for the last 2 weeks, and just before we started this podcast, my girlfriend, whose space I am in right now, is a nurse and has been under quarantine for exposure for the last 2 weeks. So I am taking this pretty seriously, because by extension, you know, if she was tested once and it came back negative, but she's still symptomatic. So we went down for another test today. We'll see if it becomes positive. But I'm taking it pretty seriously because I may have it as we're talking right now.
And, you know, that's a good way to wrap it up. That, of course, it's serious. A lot of tragedies occurring. Ireland took the social distancing seriously. We've hardly left the house really, in weeks. And now they've locked down the last week or so, pretty much. But the reality is, in the next couple of weeks, with the antibody testing, the initial reports from Italy, California, and the UK, we'll see. We may find out it's vastly more prevalent than assumed. Like you say, like the Diamond Princess, that the death rates are far, far lower than were assumed. And we'll start seeing also more and more data allowing for lag times as to how lockdown versus smart social distancing measures really kind of stack up. And I think in a few weeks, we'll see what happens, but I'm guessing the world will get pretty smart after this terrible scare, reflect on this, and maybe start getting smarter in both sides of the ledger and just taking balanced crisis management, steady as she goes. Smart human qualities will rise to the fore.
Yes, let's hope it keeps being less serious than initially forecast, and that our politicians exceed our expectations.
Great way to finish it. Hey, thanks a lot, Tucker, and we'll check back in a couple of weeks or whenever when the data emerges more and see how on point we were or off point. I mean, that's okay too. It's all judgment and it should be discussed openly. The last thing we want are infringement of freedoms relating to what's already a very difficult situation.
Absolutely. Completely agree with you, Ivor. Thank you again for having me on. It's great talking to you as always.
Ditto. Thanks, Tucker. Bye now. Thanks for tuning in, guys. If you're watching on YouTube, you can see my subscribe button in the middle of the screen, and go to extratimemovie.com to see our fascinating new documentary on stopping and reversing heart disease.